there's not a role for screening today in kidney cancer. So I'll focus on imaging, which I think is a broad enough topic for 10 minutes. Um, so I figure I will discuss some of the unmet clinical needs. As you know, imaging has been traditionally used to find tumors and to measure tumors. In the spirit of raising controversy, I'm going to argue there is a lot more information in the images that we're not using today in oncology. So I'm going to give you some examples of that. I'm going to talk about active surveillance, neoadjuvant therapy, and metastatic disease. So starting with active surveillance, you're all aware that the incidence of kidney cancer has increased dramatically in the last few decades because of the use of cross-sectional imaging. We detect now 70% of kidney cancer is diagnosed in imaging studies done for another reason. So here you have a patient, 48, female, with an incidental 1.8 centimeter renal mass. The imaging appearance, as I'm going to show you this later, is very suggestive of papillary tumor. This patient gets a follow-up 6 months later. If we use traditional measures, it goes to 1.9 centimeters. So I think most urologists will be very confident in following this patient on active surveillance. Now, we do dynamic imaging on these scans in the coronal plane, and then we do sagittal images. So you can see this is a very round, nice, smooth tumor. And 6 months later, this tumor now is infiltrating the perirenal fat and is infiltrating the renal parenchyma where it wasn't 6 months earlier. Okay, if you measure the tumor, this is still a valid candidate for active surveillance, but the phenotype is telling us that this is an extremely aggressive tumor. And in fact, this tumor was treated and came back despite the small size as a papillary grade 2 renal cell carcinoma, not a good candidate for active surveillance. So we know these days that depending on the histology, the patient has a different prognosis, and we know that clear cell stage by stage has a worse prognosis than other phenotypes, so the other histology subtypes. So recognizing clear cell will be important, particularly when we're considering patients for active surveillance. So we have been doing this with imaging, with multiparametric MRI, using standard sequences, T2 and contrast-enhanced images. We can actually, using this algorithm, predict the histologic subtype in small renal masses. So how well do we do? We created a clear cell likelihood score, and as you can see here, as the score goes up from 1 to 5, the likelihood of clear cell goes up, and the likelihood of non-clear cell goes down. And this was actually pretty robust performance across 7 different radiologists looking independently at these images. In fact, the diagnostic performance was around 80% for sensitivity, specificity, and accuracy. As you can see here, for a clear cell likelihood score of 1, 2, the specificity was 95%, and the positive predictive value for non-clear cell histology was 93%. So we believe that this can replace biopsy in some cases. Biopsies are not liked by patients. They're invasive. Sometimes they're not easy to do, and sometimes they give us an incorrect histologic diagnosis. In fact, we do well for other subtypes as well. For papillary carcinoma, we have a sensitivity of 80% and a specificity of 94%, and there's definitely an opportunity to improve the performance in other subtypes, including benign disease, fat-poor AML, and oncocytoma, but overall the accuracy was pretty good for all histologic diagnoses. Now, moving along, neoadjuvant therapy, as you know, there is not currently good options for neoadjuvant therapy in kidney cancer. And one can ask, what's the reason for that? And probably because we don't know how to choose the right therapy for the right tumor. We don't know how to identify the patient is going to benefit for the neoadjuvant therapy. I will ask the question, is a tumor biopsy enough to make that determination? And is heterogeneity a big problem in this scenario? So let me show you a couple of examples where I think the imaging phenotype may help us substantially. You heard about type 1 and type 2 papillary tumors earlier. This is a study that we performed, and as you can imagine, type 2, or you can expect type 2 papillary tumors do worse than papillary 1. That's been reported before. But actually, if you look at the imaging phenotype, those tumors that are well encapsulated, well defined, regardless of the type 1, type 2, actually do well. Is the infiltrated phenotype that actually does poorly clinically. So this was independent of size, stage, grade, and pathologic type 1 and type 2. So it's actually a subgroup of type 2 papillary cancers that do really bad and seems to be predicted by the infiltrated phenotype. Now, this is a study from the UCLA group that looked at 28 imaging traits in clear cell carcinoma, and they asked the question, what imaging trait correlates to a previously described SPC score, which was based on 259 genes that correlate with poor outcome in clear cell carcinoma. And they found 4 traits that correlated with that SPC score. And when they combined those 4 traits, they created a composite radiogenomic score, and then they looked at the ability to separate poor outcome from a good outcome, and actually the SPC score and the radiogenomic score do exactly the same way, both in predicting the same way in a validation core as well as in obviously in the training set and validation set. Now, what's interesting about this study is that other than necrosis on imaging, the other 3 imaging traits all speak to the interface between the tumor and the kidney. Again, indicating that the infiltrative phenotype on imaging is a really important aspect that tells about the biology of the tumor. What about contrast enhancement? We have shown in this paper before that clear cell carcinomas enhance more avidly than papillary tumors and chromophobes. That makes sense because of all the things that you heard before about the HIF pathway. These are very angiogenic tumors, and in fact, we can distinguish almost perfectly with a single measurement between clear cell and papillary tumors. So how can we use this clinically? If you have a patient with a mass, an IVC thrombus, and you don't look at any other thing about this patient and you predict clear cell histology, you're going to be right 70% of the time. If you say papillary tumor, you're going to be right only 5% of the time. So here you have a case with a large renal mass, an IVC thrombus, and lung metastasis. It was biopsied. In the pathologist's defense, the biopsy wasn't optimal. It was a very small amount of tumor, as you can see here. But the best they could do is to call this clear cell, advanced clear cell renal cell carcinoma, and the recommendation was to treat with sunitinib. This patient then went to MRI to see if it was a good candidate for the bulking nephrectomy. And here you have the dynamic series from the MRI. And what you can appreciate is that the tumor and the thrombus enhance very little throughout the entire study. And in fact, we can quantify that very easily on the PAC station. And you can see how this tumor is not behaving as a clear cell carcinoma, it's behaving as a papillary tumor. So based on this, we actually recommended a rebiopsy of this mass, which was done, and the repeated biopsy, which was now much better quality, came back as papillary renal cell carcinoma, and the recommendation was changed to tenserolimus. So again, there's a lot of information in these images that we're not necessarily using before we decide on what treatment for the patient. Now, we also know that, or we're starting to know that some patients may do better with TKIs and others with immunotherapy. So there's this concept of the proangiogenic tumor, and it's based on the expression of genes that are related to the angiogenesis. And I will ask the question, is the biopsy anywhere in this tumor going to give you the information that you need to decide if this is a proangiogenic tumor or not? Well, let me show you a 3D perfusion map done with an MRI sequence that we have developed, the 3D cell technique, where you can actually appreciate in red those foci where there is actually intense perfusion, intense angiogenesis in the tumor. You can see that not the whole tumor is not actually angiogenic. There are very distinct foci in this tumor that are angiogenic, whereas the rest of the tumor is actually relatively low perfusion. So depending on what you biopsy, you may get completely different answers. And it's not just RNA expression, it's also mutation. What about this tumor? This is a BAP1 positive tumor throughout, 80% of the tumor. But that nodule at 7 o'clock is actually a BAP1 negative nodule. So you can imagine, depending where you biopsy this lesion, you're going to get a completely different answer. So our argument is that we can use imaging to define those areas, maybe based on perfusion, contrast enhancement, or even fat content on the renal mass. We may be able to predict those areas in the tumor that are more aggressive than the rest of the areas. Now, I mentioned this ASL, arterial spin label, and this is a sequence that uses the endogenous blood as contrast. So what you're going to do is use the spin in the arteries, and you're going to label those spins. So you invert the magnetization, and if you wait a certain amount of time, that blood is going to perfuse the tissue and decrease the signal in the tissue. So if you do 2 images, one with the label and one without the label, and you subtract the 2, you get an image that looks like that, where the high signal intensity corresponds to perfusion, and you can actually measure tissue perfusion in mLs per 100 grams of tissue per minute. So again, how can we use this clinically. So this is a patient with a prior right nephrectomy and a path-proven left clear cell carcinoma in her single kidney. The patient came back a few months later, and now you can see that the left mass is slightly larger, but that the perfusion has increased dramatically in only a few months. So we were very concerned about this, and we brought it back only 3 months later, just to show now that to confirm that the mass is clearly growing and the perfusion continues to be high. So because of her only kidney and the fact that it was relatively central, it was thought that retreatment with radiotherapy was the best option. Now, 1 month after therapy, now the tumor is even larger, so everybody's getting nervous. But when you look at the perfusion is actually going down. So we assume that this was most likely radiation-induced damage, or radiation-induced edema, rather. And 3 months later, now the perfusion in the tumor is completely gone. The tumor is starting to shrink, and she actually lived 3-4 years longer. She was a very old patient, but she never developed metastatic kidney cancer and was able to live with her kidney and preserve renal function. Now, what about metastatic disease? How is heterogeneous affecting us in characterizing these responses? Well, let me show you an example where maybe we can do better than just measuring tumors. This is a patient with 3 masses, one in the right adrenal gland, one in the pancreas. I don't know if I have a pointer here. Yeah. So one in the adrenal gland, one in the pancreas, and one in the spleen. So we also did an ASL scan here, so you can see that the perfusion is very high in all 3 metastases. This was one of the patients enrolled in the HIF2 phase 1 HIF2 inhibition therapy that Jim Brugarolas mentioned earlier, the phase 1 trial. And 2 weeks after therapy, this is a companion study that we did at UT. And you can see that 2 weeks later, there's excellent response in the spleen with complete decrease in the perfusion. A relatively good response in the pancreas with decrease in perfusion as well. But the right adrenal gland is not only not decreasing in perfusion, it may be even a higher perfusion than at baseline. Now, this is a heterogeneous response in to HIF2 inhibition in this patient. But what is interesting about this is that predicted what happened almost a year later. You can see that a year later, the spleen still has an almost complete response. This is at least a partial response, but the right adrenal gland has exploded and is actually much larger than at baseline. So again, the lack of change in perfusion predicted what was going to happen months later. It will be very difficult to make, obviously, that assessment using standard RECIST criteria. And this is why some are developing more quantitative measures of viability in metastases and primary tumors. So this is work from Andy Smith, where they have looked at the vascular tumor burden. So what they measure is how much of each metastasis is enhancing, and they're able to segment every single metastasis in a very quick fashion and provide a vascular tumor burden quantification in each patient. And when you compare to a standard criteria, including RECIST and others, the vascular tumor burden actually does better than the other criteria to assess response to tyrosine kinase inhibitors. What about immune therapy? We're all aware of the challenges of pseudoprogression, where you see tumors exploding very, very rapidly, but then you do a confirmatory scan, and those are actually responses, not progressive disease. But the truth of the matter is this is relatively uncommon, and we also know that by doing a confirmatory scan, we can differentiate between pseudoprogressions and response. And that's why we use the iRECIST criteria in general now for these trials. But I think this is a very, very exciting work from my colleague Shankar Sun, and he's working with Jim on this project, where they're using immunoped. They're basically labeling Atiso with sarcanium 89, and what they've shown in this preliminary study and the preclinical study is that the activity or the uptake of the radiotracer actually predicts the expression of PD-L1 in these tumors. So this potentially could actually be used to define what patients are going to benefit from immunotherapy and also assess response after the therapy is initiated. And this has been, the IND is being processed as we speak. Finally, bone metastasis is a very big problem in kidney cancer. These are lytic metastases, so traditional methods of assessment don't work well. Bone scan has a lot of false negatives. It's about 65 to 70% sensitivity. CT is not ideal. PET with FDG doesn't work well in kidney cancer. Sodium fluoride works great, but it's not covered by CMS. It's very expensive and not available everywhere. So we argue that whole body MRI may be a better way to do it. Now, if you're going to do that, you have to be able to do this quickly, because right now the current techniques, you can't put a patient for 2 hours just to scan the whole body. So we have developed this sequence. It takes about 7 minutes to do the whole body. If you put it in the context of a whole body MRI with and without contrast, we can definitely do it in the standard clinical time of 45 minutes to cover the entire body. And we have actually shown increased detection of metastasis. In this case, X-ray and CT failed to show the lesion, but the MRI clearly shows, with the detect sequence, clearly shows the metastasis in the femur.
So can you see this without the enhanced? Can you see the same tumor with the regular MRI?
You can, but you will only cover one area. You wouldn't screen the entire body. Yeah, absolutely. You will see it if you do a pelvis MRI. All right, so just to finish, I think the role of imaging is going to evolve. I think we're going to be able to select better tumors for active surveillance. We'll be able to monitor those tumors and find when those tumors are actually evolving into more aggressive disease and they need to be treated. And in the metastatic setting, I think we're going to be developing more quantitative techniques to assess response and also address heterogeneity and really help oncologists decide when combination therapies or change to a different therapy is necessary. So that's what I have. And, thank you very much.
Really interesting stuff. I think the radio-labeled atezolizumab is really may hold promise in helping us to develop who to treat if that's going to actually correlate or associate with who may benefit from the therapy. Has that been done with other antibodies like bevacizumab, for example? I mean, that probably would. I'm not sure it would predict as much.
You may know. I think in Europe they're using a different target.
I mean, I think the advantage of atezolizumab is precisely that the Fc portion of the antibody is mutated. So in other words, the antibody is only going to bind to the PD-L1. It's not going to be recognized by macrophages and other cells. And that's why we chose to start this with atezolizumab.
Really interesting.
Are you looking at the entire antibody? I mean, you know, the antibodies really don't image very well. And
well,
you go with a di-body, mini-body. I mean, just, you know, cut down the size.
Right. So, in fact, when we started this project, we were collaborating with Anna Wu, who's a leader in terms of
she's good.
Right, in antibody engineering. I think so. The whole antibody has one advantage, which is that it hangs around for longer, and the other ones get cleared quickly. And we are labeling with zirconium-89. So the problem with the whole antibody is that if you image right away, you're just going to detect blood everywhere, and as you saw, there was a fair amount of background.
Right.
But because we are using a tracer that has a very long half-life, we can wait and image later and hopefully reduce the background and be able to pick up the signal. With the smaller fragments, one needs to work out a different type of radiochemistry, and conjugating with zirconium is apparently very straightforward.
I think zirconium is great. I don't know why everybody doesn't use it.
I mean, I think you get more radiation exposure because it's a longer half-life and so on.
I think it's also a matter of having the cyclotron with the capability of the zirconium, which is not all cyclotrons can do it.